Adolescent Suicide by Jasmine K. Solomon. Due to lack of identification and treatment of depression, suicide rates among adolescents are climbing. Suicide in 10 to 14-year-olds has tripled over the past 15 years. 10 to 14-year-olds is the focus of this problem. They are the most susceptible to unnoticed mental disorder and suicide. They have the most significant increase in suicide rates over the past 15 years. There are many contributing factors. Lack of medical treatment for depression and mental illness. Depression is one of the most common mental disorders in the United States. Depression is one of the top risk factors for suicide. Early onset of puberty is also a factor. Drug abuse and situational factors such as problems at home. Adolescents who are bullied are more likely to attempt suicide. Social determinants of health and factors. Psychological, depression. Biological, early onset of puberty. Societal factors such as decreased access to health care, prescription painkiller abuse, and bullying also affect this age group. Lack of medical treatment, drug abuse, early onset of puberty. Economic instability, adolescents in lower incomes. Physical environments. Living in a rural area, there is less access to mental health services. Education. Adolescents without education and resources are higher risk for suicide. Community. Adolescents with no family or religion or school support are more likely to commit suicide or attempt suicide. And healthcare. Again, not having medications or treatment for mental disorders or counseling services for those who need it also make this population higher risk. Social ecological models to address adolescent and teen suicide. Policies that affect this population are Baker Act or involuntary examination. Community, television shows, the news. Organizational, such as community-based programs. Interpersonal, parents and family support systems. And individual or personal beliefs, such as religion. Policy. The Florida Mental Health Act of 1971, also known as the Baker Act, allows involuntary institution and examination of an individual with evidence of possible mental illness. The individuals involved must be at harm to himself or others. Community. A very popular trending topic on social media, news, and television is a series released with a target audience of adolescents and teens called 13 Reasons Why. This series is a story of teenage girl's life and her suicide. Organizational. Community-based programs for children and teens are included in this. Interpersonal, parents and families. Individual, personal beliefs and religion. Interventions. So some of the interventions that are going to help with this problem are social media screening, signs of suicide programs put into schools, and SSRI or prescription use increased within this population. Social media screening. Social media screening, the online screening of adolescents and teens through social media sites, searching with sites for terms of indicative of suicide, depression, or self-harm. The target goal will be to use school social media sites to identify adolescents and teens that are at risk for depression or suicide. The goal is to connect with this group to offer services and referrals through social media and their school's counseling programs. More than 50% of children have social media by the age of 10 years old. Social media is one of the main sources of communication and self-expression in today's adolescents and teens. This is how this program is going to reach out to the population and make a difference. Most U.S. middle schools and high schools have social media pages already accessible to students. Signs of Suicide Program. Implementation of the Signs of Suicide Program will prevent middle school and high school students from suicidal behaviors and open their eyes and give them the knowledge to see the people around them who are at high risk. Students are already required to take health classes in 6th, 8th, and 10th grade. This program will be implemented into 6th and 10th grade health classes These students will complete the Columbia Depression Scale screening at the beginning and at the end of each of these classes. SSRI prescription use. Increasing SSRI use and the availability in depressed and high-risk adolescent teens. This will encourage and educate physicians and mental health facilities on the advantages of SSRI use in critically depressed youth. The advantages versus the risks make these medications an advantage to cutting back on suicide in teens. These medications will ensure that the teens will get what they need, and they will be available through the local health department to low-income families. Successful evaluation. Social media screening. At-youth risk are identified through this program. They are identified and the counseling and referral services are provided to them. This is how we're going to know that these programs are working. Signs of suicide programs. Secondary youth risk surveys will show that there has been a positive change from the initial survey. So the surveys will be done at the beginning and at the end of the programs in 8th and 10th grade to show the change. There will also be HML software that will show a decline in the number of suicide attempts within the schools in the areas that have the signs of suicide programs. SSRI and prescription use. Data will show as SSRI and prescription use is increased and the number of suicide attempts are decreased. Social media screening. It will be evident that the implementation of this program has been successful when the population of youth identified uses the counseling and referral services that the program provides. Implementation of signs of suicide. It will be evident that implementation of signs of suicide program is working when the results of the survey show positive change and the HML software shows change. SSRI availability. It will be evident that this intervention is successful as data shows the SSRI and prescription use increases the number of suicide attempts and decreases after the medications have been prescribed. Overall success of all these programs will be a decrease in suicidal behaviors and a decrease in overall suicide in 10 to 14-year-olds. This will be evident by reporting data and showing that in the area where these programs are implemented, that the numbers are decreasing. Challenges and barriers. School board approval for both of the first two programs will be a challenge. After these programs are approved, there will be positive change in the school systems and within the community. I believe there will be positive feedback from the community and the numbers will show for themselves that these programs are working. Program funding and training for employees. This will come through the Department of Health in each state and through funding for depression and suicide programs. Software and oversight. There are software products out there that provide the services that are needed to track all the data, and oversight of these programs will be in public health for each community and for the counselors in each school. Increasing information of SSRI success in clinicals and physicians. I believe that this will be overcome by putting out data and continuing education for healthcare providers. Logic model. Due to the lack of identification and treatment of depression and suicide among adolescents and teens, we will implement signs of suicide program, adolescent screenings, and SSRI prescription use availability. Through our healthcare team, we will put together all these programs, and the end result will be a decrease in suicidal behaviors and a decrease in overall suicide in 10 to 14-year-olds. Thank you.